welcome to our Palliative Care ECHO clinic today. We'll start with introductions as we do through ECHO. I am Troy Jorgensen. I'm the program manager for Project ECHO Nevada. Go ahead.
And I am Dr. Conrad. I'm one of the hub team members for Palliative Care ECHO.
Hi, Dr. McCaleb, Palliative Care Team ECHO hub member.
Hi, this is Dr. Muhammad Hasabullah. I'm a hospice and palliative medicine fellow.
Good afternoon. I'm Suram Furuhi. I'm one of the geriatric fellows.
I'm Jen Pierce, one of the hospice and palliative medicine fellows.
Wonderful. And Kim, our other hub team member, please go ahead.
She's muted.
Just a second, I'll take you off mute. So it might pop up a little thing on your end asking, there you go.
Hi, Kim Anderson, Vice President of Business Development, a hub member and also Vice Chair for the Palliative Care Quality Life Council.
All right, thanks, Kim. So then we'll go out to our spoke sites joining us today. So we'll start with Jessica Rodriguez. I'll take you off mute. If you could please introduce yourself, Jessica.
Yeah, my name is Jessica Rodriguez. I am currently not hanging a license anywhere, but I currently work at the Outpatient Wound Care Center at Spring Valley Hospital in Las Vegas.
Welcome.
Wonderful, good to have you, thank you. Someone who's joined by telephone, your screen name is Executive Assistant. It looks like you're joined by phone, so it's *6 will unmute you and we'll be able to hear you. Go ahead, you're off mute now. Could you introduce yourself, please?
Oh.
Okay, maybe you don't have a microphone, so if you could write. Yep, there you are, go ahead.
She's
okay. Hi, Bree Santrasiri. I'm from Infinity Hospice Care in Las Vegas, and I currently serve as the Nevada My Hospice Ambassador with NHPCO and HAN.
Welcome.
Excellent, great to have you today, thank you.
Thanks.
P. Paulina at Health Insight, please go ahead.
I'm with Comagine Health. I'm a nurse practitioner, and I also serve on the Nevada Pulse Board and newly on the State Palliative and Quality of Life Council.
Excellent, thank you for joining us today. Next is S. Tobin. Could you please introduce yourself? Again, it looks like you're joined by telephone, so it's *6 will unmute you and we'll be able to hear you. Yep, there you go.
Yes. Good morning. My name is Sarah Tobin from Las Vegas. I'm with Dignity Health Outpatient Case Management.
Wonderful, thank you. Alan, you're next. Go ahead.
Sorry about that. Alan Fisk and Elko technical support.
Thanks, Alan. Next is James DeAndrea. James, I've unmuted you, so if you could introduce yourself, please. Looks like you were joined by telephone, so there might be another mute button you got to unmute there, and then we'll be able to hear you for introductions.
If we know, can we introduce
You can, absolutely, yeah.
I'm going to introduce Dr. James DeAndrea because he's one of our colleagues. He is a psychologist at the VA. He works at our community living center and throughout the hospital. So welcome, Dr. DeAndrea. Thank you for joining us.
Thanks. Next is Emily Warnock, psychiatry resident in the CLC with Dr. McCaleb. Thanks, Emily. Next is another folks from the VA. It's
Esabois.
Okay. I've taken you off mute. Could you introduce yourself, please?
So in case he doesn't, there he is.
Go ahead. We can hear you. Could you introduce yourself, please? Okay. Do you want to go ahead, Dr. Conrad?
I'm gonna hope that Dr. Esabois is in good health right now, and he's one of our hospice fellows who's joining us remotely for today's session.
Thanks. Dr. David Bayan, please go ahead.
I'm David Bian. I do hospital medicine and some primary care from Ely, Nevada.
Thanks, Dr. Bayan. Greg Merciolo. Greg, could you introduce yourself? I've unmuted you.
Yes, I'm a critical care nurse at Carson Tahoe Regional Medical Center.
Oh, exciting.
Wonderful. Good to have you joining us today. Next is Caitlin Riley. Please go ahead.
Hi, I'm Caitlin Riley. I'm a DNP student at UNR. My background is in adult critical care here at UC Davis, although I'm currently working as a nurse in the NICU at UC Davis.
Thanks, Caitlin. Good to have you joining us today. Next is Kirsten. I've muted you.
Hello there, I'm Kirsten Hudson. I'm a licensed clinical social worker at the VA hospital in Reno.
Yay.
Wonderful. And we had another group join us, Heart Rock Care. I'll unmute you. Could you introduce yourselves, please?
Yes, there's two of us here at Heart Rock Care. We're a non-medical and in-home care agency, Kathy and Elisa.
Wonderful. Thank you very much. All right, so we will move on here through our agenda for the day. And as we do through ECHO, we want to support you with your challenging patient cases or any concerns or issues you're having at your facilities. So we'll open it up right now. Feel free to unmute yourselves with the little microphone icon in the lower left corner of the Zoom window, or write something in through the chat box. Any concerns with your patients, any concerns with things happening at your facilities, please feel free to share right now. Okay, not seeing anybody willing to share, so we'll obviously be available for that throughout the session. So if during the presentation you think of a specific situation that has happened to you, please share that with us and get some discussion going. So I think we'll get going here then with today's presentation. So this is just a disclaimer letting you know that we do record all of these sessions and post them online for posterity. So if you don't want to be in those videos, please let us know. We can edit you out and make sure, yeah, you're not in that. Next is, if you do present a patient case, please remember to not share any protected health information, no HIPAA violations, anything like that. Since this is a group setting, we want to make sure to maintain confidentiality. And we'll get going here then.
Thank you very much, Troy. This is, you can all read, I know, this is our hub team's aim and mission statement. And really, in a nutshell, what this is saying is we are hoping to provide the education and resources and encouragement and empowerment for any of you to start adopting elements or even complete practices in palliative care, whatever setting that you work in. And anything we could do to make it easier for you to take those steps or improve your skills, we want to hear from you, because we want to give you what you need so that we can get good quality palliative care throughout the state of Nevada. Next slide. I should have looked at this. So today's topic is outpatient-based palliative care. You may have noticed a trend here for any of you that have joined us for a few sessions. We're working really hard to lay the groundwork for what palliative care is in its entirety, in the variety of settings and circumstances. And so today we're going to be focusing on outpatient palliative care. Last month you heard about home-based palliative care. Next month we'll be talking about nursing home-based palliative care. And joining me today and sharing this presentation will be Dr. McCaleb and Dr. Hasabala. We, as a group, have no conflicts of interest to disclose. And the learning objectives today, we're going to talk about models of delivery, talk about the benefits and impact of outpatient-based palliative care, talk about criteria for referrals to outpatient-based palliative care, talk about some of the barriers to providing good outpatient palliative care, and then we're going to briefly go over an approach to billing for outpatient palliative care services. So starting off today, just thought it'd be good to have some fun on a Friday, start off with a laugh. I think this kind of represents palliative care, that things may not always be as they appear. And I'm going to turn the first part of our presentation to our Dr. McCaleb, and he's going to discuss some of the models and processes related to outpatient palliative care. Dr. McCaleb.
Thank you, Dr. Conrad. So to begin with, in terms of a first things first approach to today's topic of outpatient palliative care, I will touch on briefly the definition of palliative care and understand that the delivery of outpatient palliative care and the specifics of that still aim to provide relief to patients for symptoms of advanced chronic disease and maintain the best possible quality of life for patients. And that truly includes whatever stage of illness an individual is in or approaching. So more specifically, what we would like to discuss today is outpatient palliative care. And starting with a framework of two general types of delivery and approach to care include the specialty consultation model, which is essentially a model for referrals to outpatient palliative care consultation with a, to use plain language, one and done consult approach. So in other words, if a referring party, a clinician, whether that be a physician or an advanced practice nurse, refers to an outpatient palliative care specialist, the expectation would be that that patient would be seen in an outpatient palliative care clinic, and a set of recommendations, typically compiled in an H&P format, would then be forwarded on to the consulting party. It's more of a sort of one-time delivery and can encompass all manner of interventions and or palliative recommendations. The second type of delivery is actually the more common type, and that would be the longitudinal co-management, which can take place in clinics, in homes, or residential living facilities. And this is where palliative care becomes truly embedded with, and the palliative care providers become part of the care team for the patient who's being referred. And so this type of a longitudinal management strategy would be implemented at the time of consultation, and the recommendations would, moving forward, be something that the palliative care physician would anticipate to manage on an ongoing basis. And so there can be, just so you know, between both of these different delivery approaches, both specialty consultation and longitudinal co-management, they can vary widely in specific details. Specifically, physical location, patient census, primary illnesses seen, referral sources, etc. And just to help you understand, the longitudinal co-management strategy is the one most frequently used by oncology. It is a situation that it's been widely acknowledged that and increasingly recognized as the palliative care is truly vital to comprehensive cancer care management. Next slide. And so understanding better some of the details surrounding outpatient palliative care models, I want you to all keep in mind that palliative care is not a specific place, it is not a patient status, and it is not limited by curative intent. Home-based palliative care specifically was addressed last month by my colleague, Dr. Helena Russell, and she presented a full echo's worth of information on this topic, so I would highly advise going to the lecture bank for this echo series and revisiting it. But suffice to say, palliative care can be delivered in the home setting on a consultative basis between a provider or an interdisciplinary team and a patient who is in their home.
And longitudinally in the home.
And longitudinally in the home. And what is nice about that, I think what is one of the most favorable elements to home-based palliative care is that you're seeing the patient in the environment that they most typically feel most comfortable in. And so it is nonetheless a clinical encounter, but the degree of comfort that a patient might have, and especially in terms of planning around family members who maybe live in the home or plan on being in the home, can be present for these kinds of discussions. And so it can look a lot like a full-fledged interdisciplinary care meeting. So the only other note I wanted to make is that palliative care consultation in the outpatient setting in and of itself is a separate type of consult from a hospice consult. So palliative care consultation is an all-encompassing, patient-centered consultation which focuses on elements of symptom management, which focuses on transitions in care, which focuses on a patient and their individual values and close relationships in their lives. A hospice consultation is a separate type of consultation, and hospice may very well come up in a palliative care consultation. However, I just wanted to mention that a hospice consult might also be a type of consult where the sole purpose and objective for that consult would be to qualify somebody based on their medical condition for hospice. And palliative care consultation is not intended to be an exclusive hospice qualifying consult. And of course, with the current state of medicine, reaching out to rural areas, of course, I've mentioned telephonic palliative care and VTEL palliative care. We do provide this through our clinic in the VA. And to touch on what will be brought up again later, early co-management and earlier referral, the better. So
the stronger the evidence of outcomes, which is a perfect transition to what I'm going to briefly talk about. I want to talk about what the literature says about outcomes of outpatient-based palliative care. This body of literature isn't quite as robust as the palliative care outcomes or benefits in general, because really palliative care really had its roots in an inpatient consultative model setting. But clearly we know from some of our other presentations the benefits and impact of palliative care in other settings. But even though this is not as robust of a practice, there's still some good information out there. In this first slide, this is summarizing an article published in JAMA, Internal Medicine, in 2017. And this was a review that synthesized evidence that describes the relative effectiveness of outpatient palliative care relative to usual care, its drivers and associated costs. And what this review did was they looked at a number of domains, and then they categorized the strength of the evidence into moderate or low evidence or no evidence. And just to summarize the article, they found that through a variety of methods, and so they looked at 16 publications of 13 fair to good quality studies, and they acknowledged that while outpatient palliative care seems to improve quality of life and reduce resource utilization, such as hospital and emergency rooms use, there wasn't evidence that could recommend a specific model. But despite different models, such as embedded, longitudinal, consultative approaches, different approaches to delivering outpatient palliative care, on the whole, there was moderate strength of evidence showing that it improved quality of life, reduced resource utilization, and improved patient satisfaction. And though the evidence was weaker, there was still, on the positive side, support for showing that it improved survival, at least in cancer patient studies, improvements in symptom burden, mood, and caregiver outcomes. And in a little bit older of a study that was more of a meta-analysis. This was published in the Journal of Palliative Medicine in 2013. This was a review of published peer-reviewed outcomes research looking at both observational studies as well as controlled trials of non-hospice outpatient palliative care services. And they looked at a variety of domains. They looked at patient, family, caregiver, and clinician satisfaction. They looked at outcomes such as symptom management, quality of life, and mortality, as well as healthcare utilization. And some of the models looked at were in-home palliative care or home-based palliative care consultation within a primary care clinic, telephonic nurse practitioner-led psychoeducational interventions, as well as early palliative care longitudinal co-management. And the results of all these studies, including 4 very well-designed randomized interventions, along with a growing body of some non-randomized studies, indicate what this slide tells us, that outpatient palliative care improves satisfaction, improves symptom control and quality of life. It reduces healthcare utilization, such as hospitalizations and emergency room visits, and lengthens survival in a population of lung cancer patients. So all of this together tells us that the evidence supports the value of outpatient palliative care. It supports the ongoing expansion and innovation of outpatient palliative care services throughout the continuum to all patients with serious illness. So, this being said, I would like to hand over the next part of our presentation to Dr. Hasabala, who's going to talk a little bit about the evolving model of palliative care, the indications for referrals, barriers to providing it, and he's going to share a case with us. Dr. Hasabala.
Thank you for having me. So I would like to start with this slide, which help us to understand how outpatient palliative care can be a useful tool to provide early intervention for the patient. So there is 2 models here. The first one is the old one, which usually provide palliative care too late, so the patient cannot get the optimum benefit from palliative care. The second module, which is the preferred one, is to introduce palliative care as early as possible, concurrently with disease-focused care, and continue the care for family after death, and also provide psychological and spiritual support throughout the palliative care. Next slide. So this Victoria classification of palliative care, this table can help us to understand the scope of outpatient palliative care. So it basically classified palliative care according to type of treatment, if it's intended for cure, if it's intended for just comfort and symptom management, and also classify palliative care according to urgency, if it's urgent or not urgent. So the active and comfort type of palliative care, it's lie within the scope of outpatient palliative care. And the point to take from this table is we always recommend early involvement of palliative care just after the diagnosis of serious illness and not wait too late. One of the misconceptions that I commonly see, not only among patients, but only among providers and medical professionals, that they recommend to give patient time to cope and to absorb the diagnosis of serious illness. But palliative care can help with coping. Palliative care can help with observing and can help with decision-making process, which is important. Next slide. So a common question also that been always getting from my colleagues is, when should we refer to your outpatient palliative clinic? So here some of the common criteria for referral to outpatient palliative care clinic, which include severe symptoms, either physical or emotional, request by the patient for referral or request for hastened death, spiritual or existential crisis, patient delirium, assistance with decision-making or care planning, which is common through our practice at the VA, and more advanced disease with complication like spinal cord compression, brain or leptomeningeal metastasis, or progressive disease despite therapy. Next slide. So what would be the barrier to use outpatient palliative care? First barrier would be lack of performance measure, which is important to plan for future improvement. So having a well-validated performance measure would likely help with prospective planning for improvement of the services. And another barrier is the cost on both patient and health system. Another barrier is limited practice capacity, which is very indicative factor of sustainability of the outpatient palliative services. Another barrier is geographic and socioeconomic access disparities. And finally, limited knowledge about palliative care services. Not only limited knowledge about the benefit of palliative care, but sometimes misconceptions about, like, some people think that palliative care is only for end of life. Next slide. So here, a patient we saw in our outpatient palliative clinic. He's a 61-year-old gentleman with multiple comorbidities, including chronic kidney disease, diabetes, advanced heart disease, and recurrent occlusions with that is not amendable for interventions. He also had chronic lightheadedness that prevented him from driving. His kidney disease was progressing in the last couple of years, and his nephrologist predicted that he likely gonna need dialysis in the next few years. And he lived 2 hours away from the nearest dialysis center, and he also had other symptoms like fatigue and low back pain. And an outpatient consult was placed by nephrology for symptom management and to help with decision making for dialysis. Next slide. So in the outpatient clinic, we talked with the patient. We tried to explore his knowledge about what he knows so far about his health and how he see his health through the last couple of years. He did mention that he has been noticing progressing decline in his health, and he's want to know what we think about dialysis. So we asked him about what gives you meaning in life, what's important for you. He did mention being at home, being with his family, being independent, reading books, and riding his bike. So we did tell him that we don't think that looking to your comorbidities and your advanced heart disease, that dialysis will give you the quality of life that you're looking for. On the other hand, it might make you spend more time in hospital, make you spend more time in the ICU, and more time away from your family, and likely will not give you the strength to ride your bike anymore. Then we addressed some of the patients and his family questions. So the patient asked about ECMO, and he was thinking that ECMO might help him with his kidney disease. We told him that ECMO is unlikely going to help you with your kidney disease because it's a machine that help young children who have poor lungs, so it's unlikely going to help you. And then we placed a new advanced directive, pulsed and life-sustaining treatment preference note to reflect patient wishes and values. And finally, we placed a comprehensive plan to address patients' symptoms and to help with lifestyle modification.
So does anybody have any questions about this case, or have you had something similar and perhaps had a different approach?
I have a question. So if you tell them about the dialysis specifically, if you not do the dialysis, doesn't automatically shorten your lifespan when they need it?
So you're asking about whether hemodialysis, if you choose not to start it, if it shortens your lifespan. And that is a really excellent question. The short answer is it depends. Now I'll give you the longer answer. The more older a person is, with the more health problems, comorbidities that they have, the greater the likelihood it is that it can have, it can worsen your functional status and not make you live any longer than not having it. So in a particularly elderly person that might have a lot of comorbidities, they might live just as long without dialysis as with having it, perhaps even with a better quality of life of maintaining function longer. So you really have to have careful conversations. This circumstance, this case that was presented, he was a younger, he doesn't fit the frail elderly person type of description, but he had a serious comorbidity of heart disease that he had already had a bypass. He had more blockages that they couldn't do anything about. His heart disease was making him lightheaded. He couldn't even drive safely. So dialysis was coming up in the coming months or year or two in his life, and knowing that serious comorbidity of his heart disease along with the dialysis, it could have, it was expected that for him in his particular circumstances, it would cause a big enough impact to his quality of life that maybe it wouldn't make sense. And then compounding matters, he lived 2 hours away and his wife worked and she wouldn't be able to transport him. So he'd spend 2 hours driving there, 3 to 4 hours having dialysis, 2 hours coming back, along with his heart disease that was making him lightheaded. It was not, wasn't the ingredients for a good outcome. But it really depends on the answer, the circumstances.
So it's safe to say that when it comes to outpatient palliative, is basically each patient has its own criteria, one at a time.
For at least certainly for dialysis decisions, and for some people, dialysis can improve the quality and length of your life, but not for everybody.
Sure.
Well, and just to interject, I actually have the benefit of having read the paper yesterday where the numbers were quoted, because we were going to see a gentleman in his home who was stopping dialysis. And I was shocked. It said that at age 80 and older, dialysis gives no benefit. At age 70 and older, the mortality at 1 year when starting dialysis is 73% and 70% if not starting it. 3% difference, I was shocked. And then for those with these comorbid conditions, it actually is more like the 70 and older. So really not a lot of benefit.
And there, you know, the older and comorbidities, there's functional decline. Maybe you'll end up losing your level of independence. You might go from living at home to living in a group home or a nursing home. So there's a lot of things to consider for these various, what we refer to as LSTs, life-sustaining treatments. These are serious decisions, and the entirety of a person's psychosocial, personal, medical circumstances need to be taken into account for these serious decisions.
Absolutely, and I would only add that the domain of prognostication falls squarely in the realm of palliative medicine in most instances. And so, you know, Dr. Pierce mentioning that information was very important, because these standardized life expectancy tables are something that we take into account when we're providing advice. Not that we necessarily present those tables to patients, because we want this to be a very person-centered experience for the individual. But nevertheless, prognostication lies part and parcel with the outpatient palliative care consult. And I would add for this audience that if there is specific interest in discussing prognostication as a topic in palliative medicine, this is something our ECHO team would be happy to discuss further as a full presentation and product for your viewing in the future.
Right. Well, and hopefully, depending on people's interest, you know, we can talk about prognostication models in kidney disease, in lung disease, in dementia. We've got so many ideas. We just need to hear from you. I'd like to open up to the audience if there's questions about this, or comments and thoughts about this exchange we just had.
And this is Kim Anderson. I just wanted to make a comment on the slide right before this patient about the criteria for outpatient.
Please.
So often, again, I'm assuming this was a VA patient, correct? Or that we're assuming with the 61-year-old?
That's correct.
Correct. Okay. Again, I think for those of us that aren't VA associated, you have to figure out what the criteria is based on your partner or your staff as well. I personally have been involved with radiation oncology groups where they have really employed a palliative care program, multiple discipline, where the first meeting obviously occurred in the office and then the secondary follow-ups were in the home. So the criteria, although this is a guideline that we gave you with the 10, it just really depends on who your partner is or who you are and why, you know, how you're doing the palliative care, and also truly how the palliative care is funded. I know Valley Health System here in Las Vegas, which is the largest, health system acute down here in the South, just now has hired 3 separate companies to do home-based palliative care visits. Simple reason is they don't want those high-risk patients back in those hospitals. So they don't have to meet any criteria except that they've had multiple hospitalizations in the last 60 days. So just have to look at, again, who's paying the bill and who's staffing, and what their motives are as well.
And kind of a systems-based approach to criteria for referrals. That's a really, really good point, Kim.
Great case, though.
There was some commentary in the...
that was just Kim asking.
Oh, okay, sorry.
Okay. Any other thoughts? Okay, well, I'd like to tie things up just briefly, discussing both financing and billing. And Kim, I'm glad you mentioned financing. Let me jump to, am I going backwards? It sure seems like it. Okay. Before I discuss briefly, very briefly, about billing, there was a letter to the editor on some healthcare research that was done as far back as 2010, and this was from JAMA, where the researchers looked at the characteristics of 11 different outpatient-based palliative care practices, and they compared some interesting metrics just to give you an idea of what this is about. And 11 is not a large number, but they went to centers that had good reputations, that were well established, and asked them if they would participate, because they wanted to start characterizing what was out there. And what was really interesting is, from a billing perspective, or sources of funding, 49% of the practices got their funding from direct billing. Another 45% got it from institutional support. So the institution, the hospital, the hospice agency wanted to fund it because of the global benefits. And then finally, 6% of the funding was from philanthropy. So for the case that Dr. Hasabala just presented, which was a very complex, detailed patient that we had spent over an hour with, this would be typically billed as an outpatient, a new patient visit of high complexity. So you have these 992012345, 99205 CPT codes that we're using, and we would use the 99205 as this was a high complexity, high severity problem that he had with high level of decision making, and we took well over an hour on this visit. And if one needed, you could. Go ahead. Thank you. You could, if the time spent with the education and exploring the values and goals and creating advanced care plans with this patient took additional time, you could add a time-based code modifier, the 99354, if you spent 30 minutes beyond the usual services of the consult visit. And it's important when you do these things to document when you started and when you finished, and document some of the details of what you had discussed during this additional time. Now, we have much more information. If anybody's interested, please let us know. We would be very happy to get you additional resources, because we have recommendations for the CPT codes for, say, established patient follow-up visits and other things as well. But we just wanted to give an idea of what the billing might look like for the case that Dr. Hasabala presented. Any questions?
Sorry, can I ask a question?
Yeah, go
please.
So in the hospital setting, particularly in critical care, and I have found this to be true across the lifespan from working with adults to working with neonates, there is a great deal of resistance on the part of the medical team to involve palliative care. And there's just a very exclusive focus on the maintenance of life, when life is really being defined as a pulse and sometimes little else. And I'm just wondering if any of you can speak. I realize the focus of this is on outpatient care, but if any of you can speak to kind of that problem and how to kind of transition away from that model and to get some of these patients who would really benefit and be appropriate for outpatient palliative care, to get palliative care involved earlier, I guess.
I think that's an excellent question, and I think that's something that those of us in palliative care have struggled with throughout the course of our careers at varying points in time. And I would say that the single best approach to addressing the late referrals is education. I just can't emphasize that enough. And, for our part, with the School of Medicine and our HPM fellowship, we try to spread the message by reaching out and providing lectures to the medical school and including end-of-life care in their curriculum with additional hours from the standard, 1 hour that was required, 10 years ago, to now increasing it up to 3 or 4 when we're lucky. So education is really the primary, but I think to understand the benefits of palliative care for referring providers, they have to experience the benefits for their patients before they're necessarily going to be invested in placing consults. And so, I think there is an onus on us to educate, but I think there's also an onus on systems to acknowledge not just cost-effective savings and models which demonstrate that palliative care does reduce use of resources, but I think more and more national organizations like CAPC, the Center to Advance Palliative Care, and also the American Academy of Hospice and Palliative Medicine are trying to spread the word to the public, as well as specific to the state of Nevada, that this kind of care improves patient satisfaction and improves patient quality of life. And I think some buy-in on that institutional side might very well be that patient satisfaction element.
And I would just like to say, as a promotion for what our aim and mission is as part of Palliative Care ECHO, is we are working overtime to hopefully provide some tools to any of you that are joining us to start this much earlier upstream. Start learning how to have some conversations with people, identifying people with serious illness that would benefit from having these conversations, having advanced care planning. We're trying to lay the groundwork to hopefully improve everybody's comfort with these conversations and planning and approach to care. And perhaps a topic for a future ECHO model might be is, what is primary palliative care versus specialty palliative care? Because we're hoping to empower all of you to start building this into your practice. Any healthcare provider would benefit from having the skills of having basic palliative care. That's what our intention is through this clinic.
Absolutely. And two, just to add one more element, as a frontline bedside nurse, I would say the best and most effective way to encourage involvement of palliative care is to talk to your patients if they can speak to you. I know in critical care that can be a big barrier, but in speaking to and communicating with their families, being that bridge between the provider team and encouraging families to ask questions. And when you note that you feel that a patient may benefit from a palliative care consultation, and you feel the resistance of some of these misconceived ideas about what palliative care is and isn't, just simply encouraging patients and families to ask questions of their providers. I think that is a square, wonderful starting point for any frontline bedside provider who has concerns that palliative care may be appropriate, but is inappropriately being withheld.
I appreciate that. That's really good advice. And I think, UC Davis is a very large tertiary level care center, and we have both pediatric and adult palliative care teams, and I'm really surprised at the underutilization of both just across the spectrum. But encouraging the family to ask those questions is a good idea. What do you guys know about LNAC or pediatric LNAC? We offer those here, and I've been thinking about taking them through our education department here at UC Davis.
Well, so LNAC is end of life
LNAC,
education.
yeah, okay, take them. They're wonderful. The LNAC lecture series is I think it's a great springboard into understanding hospice and palliative medicine from a standpoint that will then probably put you leaps and bounds ahead of other individuals who haven't taken it, but also move you into a space where you'll have further questions that you'll want to look into. So I definitely.
I need to just jump in here really quick. I'm sorry. Caitlin, I want to kind of go back to your last question because I think it was so good. How do we get more people to use palliative care from a non-clinical side? You've got some of the best board-certified palliative care physicians up there in that ECHO group, and I think their expertise is so great. But if you can find a case that everyone in that hospital knows about and that palliative care has been about, and then simplify it. 6 months ago, we were involved in a case at a very large hospital system. The patient was there 3 years and 6 days. Don't you think everyone in the hospital knew about this patient? And we were involved in the case. Palliative care was several visits, but over several days. Again, we took the patient off the vent. It was a very peaceful death, whole 9 yards. We put it in a very simple case study, and we've been doing it to their hubs with the nurses, because again, the nurses and the physicians have to get comfortable with it. So like we're doing here is presenting an overall case that everybody can identify with. If you want UC Davis to identify it, find that really difficult patient and get a case around it.
Okay, thank you very much.
And also, I'd like to thank P. Paulina for her comment, because that once you take that LNET course, you can become a certified educator for your peers and colleagues. So thank you for that.
Yes.
That note.
Oh, I'll look into that as well. Thank you very much.
There was some questions. So any advice on how a palliative approach to care to support the patient's quality of life when they are hospitalized for an acute event?
How a palliative approach to care.
Dr. DeAndrea, could you explain that a little bit further?
Yes, I was just wondering, patients seem to like palliative care, and sometimes though they develop an acute event and have to go into the hospital, and all of a sudden the focus changes, and just symptom management and overall comfort seems to take a back seat. And is there anything that, for example, allied health providers such as myself could do to support more of the comfort aspects of care when they've been used to that and receiving that at home, if they have to be hospitalized? Or is it a communication issue with for example, the attending physicians in the hospital? Does that make sense?
Yes.
Yes. Absolutely, it makes sense. And I think one of the best primary ways of accomplishing that is through facilitating and recommending clear advance directives and PULSE documents and advanced care planning sessions, because those documents may be the only voice for the patient when they were in the setting where they were receiving more of a comfort-based or home-based approach to their care. So that was number one. But number two, I think, Dr. DeAndrea, you're making a really good point, that if palliative care is involved in a patient's care, then absolutely there ought to be some kind of a trigger to alert, especially in the longitudinal care model, that a patient of the palliative care clinic has been admitted to the hospital, much the same as an oncologist who finds out that their patient is in the hospital due to either medical complications or side effects from chemotherapy, and comes in to weigh in as a consultant. So I think we do need to do more work on figuring out how those triggers could be implemented.
And I do think, we are so fortunate at how very much embedded palliative care is throughout our local VA center, outpatient, and specialty clinics. We work with the oncologists, we go to the ICU, we go to the floors, and we are fortunate that we have such a presence in our hospital that we might have a case manager or a social worker say, this patient has a post on file that says comfort care only, but they're in the ICU intubated, can you come help? And we'll go to the ICU and say, hey, we were told about this, can we help you? And see if we can invite our way in. And we have respectful relationships that that when these discrepancies are found, people are comfortable contacting us and asking us to help in, and then we try to respectfully offer to reconcile these differences that we're seeing between documented wishes and the current care. So I think the penetration of a service in an organization could be useful in reconciling those problems.
Mm-hmm. All right. Yeah, thank you. Those are great, excellent responses. And I agree that the VA is unusual in that sense. I think in the community at large, it's a little bit different because there's greater fragmentation of services out in the community.
Absolutely.
You may also find that, like with the case I was sharing with the large hospital system, they don't have a palliative care program. We came in as, again, someone from the community. And we also had bereavement services, spiritual services. So you can reach out to some of the community partners and see if they can come into that acute setting and offer some more of those palliative care typical conversations or pieces that you may not have in the hospital or in an acute setting.
Right. Yep. Thank you.
Okay, so we are at about our time for today, so we want to wrap up and just make a quick few announcements, and then we've got a survey that we'd like you to complete. So thank you everyone for joining us today. A few new faces, so thanks and welcome. We'll be back next month. Let me get the date here. It is November 15th, and we're going to be talking about nursing-based palliative care. Is that correct?
Nursing home.
Nursing home-based palliative care, yes. So we hope to see you then. I will show our short survey. It's just asking if we met the learning objectives for today and if you were satisfied with the session. So I'll launch that. And again, we'll be back November 15th. Hope to see you all then. Thank you so much, everyone, and have a great rest of your day and a good weekend.
Thank you.
Thank you.
Thank you.